How many critically ill patients would you agree to treat empirically with antifungal to save one candidemia related death? 10. That you will say, okay, I will treat 10 patients to save one life. Anybody? What about 20? So basically one has to arrive at this number, to be very honest, that how many patients I am willing to treat in order to save one life. This is one of the biggest study till now done on empirical treatment with micafungin in patients just like our patient. Ventilation, patient had colonization, had organ dysfunction, broad spectrum lines. They gave micafungin to one group, placebo to another group. The patient is still empiric. And they calculated the sample size for significance was 36. They said, if it is below 36, I will say it will work. Above 36, it's not going to work. What they found was, definitely the sample size was 100. You need 100 patients to treat with micafungin in order to save one fungal related mortality. So that's why it was not significant. And as you can see, giving empirical micafungin, just like we do almost on a daily basis, was not found to be useful. You have to use 200 patients to save one life. So that was the study. The other observation was the discriminating power of colonization was very low, as was found earlier. Beta-D-glucan was not very useful. So just like in the diagnostic strategies, these do not help us to define this. And in fact, it was said it was final nail in the coffin. But when you look at the guidelines, there are two guidelines on Candida. One is European guideline, one is the American guidelines. What is the role of empirical treatment? They say, the American guideline, if there is a risk factor for invasive candidiasis and no other known cause of fever, that's the problem. How do I know my patient can have bacteremia? Surrogate markers, not useful in many of the studies. There they say you can use empirical antifungal. They say empiricus trial have shown it is not useful. What about the European guideline? They say you use only in patient with shock. In fact, they are very stringent. You do not use empirical antifungal in patient with just fever, multi-organ failure. The panel recommend not starting antifungal without shock and multi-organ failure. Though they recommend with shock, for which there is not much evidence, but at least they are restrictive as opposed to the American guidelines, that it should only be used in patient with shock. So I think we use very liberally empirical antifungals. And the chances are very high, 99% of the time we are shooting in the dark, and probably that is not going to help my patient. And the European guideline recommends the promotion of antifungal stewardship. We should not over-treat our patient with antifungal. So just to conclude, the challenges that we have, one is diagnostic challenge, as I mentioned, that apart from clinical suspicion, scoring system, beta-D-glucan, procalcitonin is not helping us. So I think I still go for whether there is a focal sign or not in that patient. Now, we all land up giving empirical therapy, but let me tell you, over years I have gradually started getting away. I do send beta-D-glucan. If it is less than 80, I am happy. This patient probably have bacterial infection. If it is, I don't wait for 500, but if it is 300, 400, the chance of fungemia is very high. In between, I am not very sure. And the last challenge is the multi-drug resistant infections. I won't dwell into it, Candida auris and Candida glabrata. So the echinocandin doses that we are using nowadays of Caspo, Mica and Anidula, people who are doing drug levels, they are finding it is 50% of the healthy controls. So chances are very high we are underdosing our patients with echinocandins. And so with these drug-resistant strains, we will soon have to use a much higher doses of echinocandins. Thank you very much for your patient listening.